posted on the BC website for any of you to go back to or to advertise to your friends to go and see it. Next slide, please. We want to acknowledge that the land on which we host this session is the unceded and ancestral territory of the Coast Salish peoples, including the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, as well as the Métis chartered community of the Lower Mainland region. And wherever you are in this province or anywhere on Turtle Island, we want you to reflect, continue to learn and grow both with the land and the people, and think about all the things that we can do to preserve both the land and the people, and very pertinent to today's conversation for sure. Next slide, please. So Province-Wide Rounds is a collaboration between the University of British Columbia Division of Nephrology, as well as BC Renal, and all of our health authority partners, as well as all of our industry partners. And together, we are committed to learning and sharing our knowledge, and that's why it's province-wide and not just sequestered into small rooms where people can't learn and with and from each other. Next slide. So this is a session that we've all looked forward to. Traditionally, it's usually done on Earth Day, but for various reasons, we're at the beginning of May. I'm very pleased to introduce both Dr. Carolyn Stigant and Helen Chiu. And a little bit about each of these people is important. Many of you will know these people. Helen Chiu joined BC Renal as an administrative fellow and now serves as the quality lead for patient-centered performance improvement. She holds a Master of Science in Pathology and Lab Medicine and a Master of Health Admin from UBC, and has complemented that training with training from the BC Quality Academy and the International Association of Public Participation. And she's really an advocate and a specialist in quality improvement, strategic planning, and knowledge translation through the various roles provincially and in the national health networks. She's driven by a passion for equitable health and care, and works collaboratively with people around on both human and planetary health. And Dr. Stigant is a mother, gardener, educator, and climate activist, and has been very instrumental in development and practice of environmentally sustainable kidney care. As British Columbians, we should be proud that she holds both national and international status in this realm, and has recently come back from the KDIGO Conference on Green Nephrology. She completed her nephrology training at the University of Toronto and then got a Master's of Health Science in Epidemiology through the Kidney Foundation of Canada Biomedical Fellowship. She conceived of and delivers the undergraduate UBC Medicine Lecture, The Climate Crisis, Planetary Health and Medical Practice, A Call to Action. And as I said, she's the co-chair of the Climate Change and Planetary Health Steering Committee of Island Health, a co-investigator in the UBC Planetary Healthcare Lab, and the inaugural chair of Sustainable Nephrology Action Planning called SNAP, which is a committee at the Canadian Society of Nephrology, and is proud to present the CSN in the Green K, the Global Environmental Evolution in Nephrology and Kidney Care Initiative of the ISN, and serves as a co-chair to that. She really has an amazing footprint, not a carbon emission print, with respect to everything she does in the planetary health world, and particularly with respect to nephrology. So without further ado, I'm going to hand it over to both Carolyn and Helen to take us through the BC Renal Planetary Health Strategy. Over to you.
Perfect. Thanks so much. Thanks for that kind introduction. I'm going to start off first, and I'll hand it over to Helen shortly. Just loading up the slides here. Hopefully those are visible to all and in the slide format.
Perfect.
Great. Okay. These are my disclosures, and those of you who have heard my talk know that I have some additional disclosures that I choose to share with everyone here. I would encourage you all to calculate your own carbon footprint. There's some resources here. It's very difficult in a fossil fuel-based society to get to net zero, but I pose the question to all, how do we get there if we don't achieve this individually? Adira did the land acknowledgement, but I'm speaking from the traditional and unceded territories of the Wasanich people. And these are some of the scenes of this gorgeous environment and surrounding that I'm really grateful for and that inspire me in this work every day. Hopefully you're all familiar with the objectives. We're going to talk about some of the newer literature. Helen's going to walk us through our new planetary health strategy, and then we'll try to mobilize everybody to help you in your work sphere make every job a climate job with some prioritized sustainability ideas, and then sort of inspire for the future for accreditation pathways that are on the horizon in planetary health. So perhaps an energy transition at a major scale serves as an interesting metaphor for lessening the environmental impact of kidney care. But I chose to share this because it's a rare good news story in the world of energy these days. And this is the story of how the United Kingdom has aggressively pursued and worked into law decarbonizing their energy mix. So you can see how they set these goals and how they've achieved an increase in renewables. And they closed their last coal-powered energy facility last September. And so they've now got global emissions within their country since the lowest level since Victorian era. And I thought it would be useful to look at energy costs, like in the big picture, because decarbonizing healthcare, the number one strategy is to decarbonize societal energy mix. So it may be interesting to people that per kilowatt hour, which is about the energy required to run a dishwasher, the cost of natural gas is 4 pennies, and that's equal now to the cost of onshore wind. So the message there is to get a plan and to stick to that plan, to follow through with it. We talk a lot about carbon, and I will be talking a lot about carbon in this talk, but this is sort of a good introductory slide to say it's really more than that. So I think this is a really useful graphic that says when we talk about carbon, what we really mean is all of this, issues with water, with inequality, with how we're using land, how we're consuming different things, different environmental impacts, etc. And I'm really inspired by an Indigenous Canadian scholar named Dr. Nicole Redvers, who's published on reciprocity and responsibility in our relationship with the natural world, and something that I find truly appealing, that biospheric values are intrinsically human values. I wanted to start in the literature review in a bit of an unconventional way because there's not a lot in the sustainability literature on non-carbon impacts of care. And so it's a bit of a plug, but also to highlight, I really wanted to highlight important things that were being done by other investigators in BC and how we're gaining expertise with our local resources. So this is a project that we did that was just presented at WCN. So using the abstract that was devised there, it's going to be presented at the CSN next week as well. But a group of us here, you can see the names, and Dan Martin-Newson's in there as well, and Allison Chung, our resident, looked at all of the medications from our renal formulary. And we looked at some available online information sources. One was this medicine carbon footprint formulary. It's an online free resource. And the other is a Swedish database that pharmaceutical companies and Swedish environmental and other European environmental regulatory agencies report to. And they report on the persistence of a pharmaceutical in an aquatic environment, its bioaccumulation within sort of bottom feeding species, and intrinsic toxicity of these medications. And they've got specific measures for these things. So the big picture is that about a quarter of the medications had high or very high carbon footprint, and not surprisingly, carbon footprint was dose dependent. That similarly, about a quarter of our pharmaceuticals persist within an aquatic environment. A smaller amount of them are shown to be accumulating in the adipose tissue of aquatic organisms. So of course, the concern there is that they make their way up the food chain. And that a smaller number of them have a very high or high toxicity. Other data, when we tried to be more specific about what we call environmental informed prescribing, indicated that for renin-angiotensin system inhibitors, ACE inhibitors tended to do better in multiple realms than did angiotensin receptor blockers. So that's a little prescribing pearl for environmentally informed prescribing. Amlodipine had a lower impact in most categories than other calcium channel blockers. Not surprisingly, lanthanum had the highest carbon footprint among the phosphate binders. There were some surprises here as well, because we wouldn't have envisioned that things that seem to be simple on a molecular level, like sodium bicarbonate or potassium citrate, these had very high carbon footprints. And then, not surprisingly, things that are used in the cytotoxic world had some toxicity profile associated with them. I will stress that data was unavailable for many formulary medications. So I think we're going to go on and continue to work to provide more specific prescribing information. And I'll just state right off the bat that throughout this talk, I'm going to be speaking to you about environmental features of our care, and I'm not advocating for environmental care to the exclusion of other patient factors. This is an additional thing that we factor in the quality and patient-centered care that we're administering. We just found out yesterday that this has been accepted, so I'm hoping to share this article in full with you in the near future. But our research group here, led by one of the PhD candidates who you'll hear a little bit more about later, Saba Yousefzai, we've written a primer for kidney professionals on life cycle assessment. I think we're going to be putting out a lot of literature and hoping that this is a supportive initial document to kind of orient you to this methodology. So we're using a case study of home hemodialysis with data that was collected here in BC by Saba's other colleagues, Salim. And this is just a sample of a diagram showing all of the different things that are considered within an assessment. We explain how you would consider the scope of a project. We explain how the inventory is obtained. We explain how the data is presented and derived, and then how to interpret these findings. So it's worth a read, and I hope that everybody enjoys that. There's also different scopes that can be used. So in the years to come, we'll be using these kinds of phrases, cradle to grave, gate to grave, et cetera. And that just really reflects the scope of what we're including in our analysis. So this is a really important point as we move forward and talk about subsequent studies and the planning for subsequent studies. And it's totally analogous to a clinical trial and who's included in a clinical trial and how the results may be generalized thereafter. So speaking further to that, this is our part of our Superstar group, our visit to the Planetary Healthcare Lab of Dr. McNeil's last year. This is SABA Y, SABA S. And these are some of the different environmental impact categories that we explain in the paper. I like that graphic. I think it's really helpful. So getting into some clinical data then. Everyone here, I'm sure, is at least the clinical people are familiar with the Credence trial. So this was a trial looking at canagliflozin versus placebo in kidney and cardiovascular outcomes in a high-risk population with chronic kidney disease. So this population had GFR 30 to 90. They had to have an ACR above 34. There was a median follow-up here of 2.6 years. And it was a fairly high proteinuria, so a fairly high risk group. But as we're all aware, the number needed to treat is pretty small to get benefit from kidney endpoints, cardiovascular endpoints, and for reducing kidney failure. So they did an analysis where they looked at SGLT2 inhibitor use, got the carbon emissions from that. They looked at the number of inpatient bed days in this trial in both groups, and the number of people who required dialysis initiation through the time of the trial. I'm going to walk you through some of the data. Interestingly, for the medication carbon footprint, there is no data that's publicly available for canagliflozin. And so they used publicly available data made available by the pharmaceutical manufacturer for dapagliflozin. But an important thing is that database that I'd referenced earlier, per that formulary, the dapagliflozin emissions are an order of magnitude less than a canagliflozin emission. So that's just something to keep in mind as we go forward. They modeled a low intensity bed day, and this was based upon the UK's, it's basically a ward bed, so there's no critical care level here. And this was the emissions of the bed day. And then they looked at 1 day of dialysis, so extrapolated up. This amount of emissions from dialysis is very standard. It's kind of right in the middle of the pack for the published literature of hemodialysis, and it's on the high end of the spectrum for peritoneal, but that was using UK data from 2010. So we all know that there was good clinical benefit in this trial, reduced hospitalization, reduced maintenance dialysis, both statistically significant. And looking at the emissions here, you get obviously more emissions when you're prescribed the drug versus placebo. They assumed placebo was zero. You get fewer inpatient days for people on the medication, fewer dialysis days, and that translated into total emissions of just over 2,000 tons. And what that means in real English, looking at the difference in emissions here, is that it's equivalent to 69 cars using standard cars driving a standard distance over a period of 1 year. So overall, prescribing the SGLT2 inhibitor led to about a 20% reduction. So I think it's important to note that that was a general medical bed, not a critical care unit bed, and this represents a low estimate, therefore, of potential emission savings from healthcare activities. So this, of course, is modeled. It doesn't look at global factors, but certainly holds promise for system reduction in high-risk individuals with this medication. So I will just say that we're looking at primary data collection for CKD care pathway currently underway in BC so that we can analyze the effect not only of SGLT2 inhibitors, but other preventive strategies as well. So more on that when we come back to SABA and SABA's combined work stream. So I'll hand it over to Helen here for her introduction of our planetary health strategy.
Thank you, Caroline, and good morning, everyone. With much gratitude, I'm joining you from the unceded and ancestral territory of the Musqueam, Squamish, and Tsleil-Waututh Nations, also colonially known as Vancouver. And we are really excited that planetary health has become a priority in BC Renal recently, and the planetary health strategy helps clarify how we're going to move forward. And planetary health is integrally part of our current strategic action plan, where there are 4 strategic priorities as shown on the slide. Some of them are related to planetary health. For example, strengthening the emergency management procedures and enhancing access to new medication and treatment. And there are priorities that are related to earlier intervention to mitigate more resource-intensive treatment for kidney failure later on. There are 3 foundational principles that ground these strategic actions. Next slide, please, Caroline. The anchoring foundational principle is equitable and optimal people-centered care is the hallmark of all foundational principles that should ground everything that we do as a provincial healthcare network. We intentionally use the term people-centered care, which is inclusive of person and family-centered care, because we involve both the patients and community we serve in guiding what we do. Next slide, please. The other foundational principle is Indigenous wellness. That's about reflecting on what we've learned in various Indigenous cultural safety training as settler on this land and as a healthcare worker, asking ourselves what can we do to create the space for decolonization and indigenization to take place in what we're doing. Next slide. And we also embrace planetary health as our foundational principle. That is where we consider and identify opportunity to reduce environmental impact and where we can adapt to the effect of climate change in the case of climate emergency, such as wildfires and flood. Next slide, please. With planetary health being our foundational principle, we recognize the need to systematically integrate planetary health principle into what we do. And there are already pockets of work being done, such as the life cycle assessments of various kidney treatment options, and there are environmentally sustainable kidney care practices in various kidney care settings, and we know that there are projects going on related to IV iron push ingestion for hemodialysis care in certain settings within Fraser Health, instead of using the mini bag administration that takes up more supplies. And we know that that project also improves the workflow and also staff experience as well. And we recognize that there are opportunities to reframe the QI and evaluation projects that have planetary health implication, for example, promoting transplant, living kidney transplant as the first line of therapy for kidney failure. So we need a formalized approach to embed planetary health practices in our provincial committees and key activities. Next slide. And that led us to develop a provincial strategy to guide how we advance planetary health within BC Renal committees and key activities. In terms of our approach for the development, we want to recognize that climate change disproportionately impacts the most vulnerable, especially the Indigenous and remote communities. And so health equity is central to this work. We are committed to being guided by diverse voices. And given how climate change is progressing, we need an ambitious target aligned with provincial and national goals. Our strategy also needs to be integrated with existing work, but also remain flexible to adapt to the policy that are ever evolving and the climate emergency and other factors. And of course, our actions must be practical and measurable in order to show real impacts. Next slide. At the same time, we are developing planetary health expertise in nephrology in BC, which includes various kidney health professional discipline, the nephrologists, nurses, dietitians, pharmacists, and others. And here are some of the publications by some of these experts in CJKHD, with a special series on environmental sustainabilities. And there is this really great interconnectedness of environmentally sustainable kidney care, where Caroline and these experts are connected with the other provincial, national, and international networks on planetary health. Next slide. Our strategy working group includes broad representation, and we are very fortunate to have Caroline, who is our planetary health medical lead, in chairing this group. We are also very honored to have Indigenous leader Chief Michael Rikama to keep us grounded in terms of Indigenous ways of thinking and being, and also having two patients and family partners, Paul Watson and Sharon Rikama, being part of this group. We've got representation in pediatrics, all regional health authority renal programs, and different professional discipline. The group also includes Mark Grusblum, the executive director of PHSA Planetary Health and BC Renal staff, and several of our members actually participate also on the CSN SNAP committee, the Sustainable Nephrology Committee, where Caroline is the chair, and there is also Sarah and Blake who are members. Next slide. This is our project overview. As we started last year, we built on existing work and thought about how we can work intentionally together to really make change, because we don't want it to be a greenwashing initiative. We conducted an environmental scan at the beginning, and we were excited to hear what is being done provincially and in other health authority. So we really work to ensure that the renal strategy is aligning and complementing those efforts. We conducted our baseline survey last summer to gauge current perceptions, practices, and challenges within our provincial network. And after that, we put everything together into an actionable strategy and developed the dissemination plan, and they were released last month. We want to make sure that there are engagement of our network and advocacy throughout that process. Next slide, please. For part of the environmental scan, last June, we conducted a survey asking network members a series of questions to help us understand the perception, practices, and challenges of environmentally sustainable kidney care, or ESKC, in BC. Almost two-thirds of the 145 survey respondents told us that they believe planetary health is important in healthcare. And interestingly, 83% of them are willing to adjust their routine for planetary planetary health, even though that may involve some inconveniences. The top barriers to for adopting ESKC practices are lack of awareness or education. There's limited time and resources, and it seems that there's lack of coordination across multidisciplinary teams. And the top ESKC practices that are really well implemented in the renal programs from their perspectives includes access to kidney transplantation, there's good use of the virtual visit, and recycling of paper products. Next slide. And so we have integrated the survey findings along with the other environmental scan materials to the planetary health strategy documents, which was just posted online last month. And for our stretch goal, we aim towards 40% reduction greenhouse gas emissions by 2030, in line with the national and provincial emissions reduction plans. We have also worked to make sure that the strategy aligns with other provincial and regional efforts in development. For example, the strategy aligns with the BC Health Quality Matrix that is being updated currently to embed environmental sustainability into the framework of 7 dimensions of healthcare quality. And that's with the vision of high quality care that honors Indigenous wisdom while aligning with the latest evidence on healthcare quality. So stay tuned for those developments that's going to come out soon. And next slide. We developed the planetary health strategic priorities by adapting from the Cascade Sustainable Kidney Care Playbook and the framework developed by Sarah Thomas and a group of Canadian renal nurses published in CJKHD. The priorities are categorized into climate mitigation, which focuses on reducing our impact on planetary health, and climate adaptation and resilience strategy to ensure that we can deliver reliable, high quality kidney care in climate emergency. Within climate mitigation, our objectives falls into 3 different areas: kidney care design and delivery coordination, which is about integrating planetary health in works carried out by our provincial modality committees through promoting early detection, prevention, optimizing use of different types of kidney treatments and medications. Operations and procurement is about collaborating with PHSA supply chain on sustainable procurement and work with suppliers to prioritize low carbon and circular economy products. For our core office, we are also reducing our operational footprint through virtual meetings and sustainable event practices where it's appropriate. Cultural cultivation and capacity building is about raising awareness and build momentum through education and training, especially those who are involved in the provincial committees and key activities within BC Renal. We also provide support through QI project funding, that's CRP-PD funding, and connecting clinical champions leading environmental sustainable kidney care efforts. For climate adaptation and resilience, we are strengthening emergency preparedness through our emergency management committee and improving the sustainable infrastructure planning through the kidney services infrastructure committee based on the latest policy and standards. Next slide, please. And advancing planetary health and kidney care really takes collaboration across our network, across discipline, the departments and sectors. Our strategy highlights how we can strategically leverage each other's role to drive change. In BC Renal, we support this through coordination funding and knowledge sharing by curating resources, supporting QI, and advocating for sustainability in healthcare. And we are working with PHSA departments like supply chain, the regional energy and environmental sustainability team, and the planetary health department in order to embed planetary health into procurement and facility planning. On the front lines, there are actually lots of opportunity where providers can adopt renal practices and educate patients about appropriate lower impact treatment options that align with what matters to them. And patients and caregiver also bring very unique insight and can be very powerful partners as we witness through the process in promoting environmental sustainability and emergency preparedness. Researchers help close knowledge gaps on how climate impacts people and the environment footprint of kidney care, which Caroline has started explaining and we'll go into more after this. We also want to work with suppliers to align products and services with planetary health principles. And so together we're shaping a more sustainable and equitable health system. Next slide. Tackling planetary health doesn't mean doing a green project in silo or laying initiative on top of one another, but it's more about seeing like the existing or new works that are both good for patient outcomes and health equity with a green lens. And here are just several examples that align with planetary health objectives and other foundational principles. Kidney Check is a CANSOLV led project that brings mobile screening to Indigenous communities, supporting early detections and timely follow-up care. As such, it also helps mitigate resource-intensive treatment, thereby reducing environmental impact, in addition to better population outcomes. Transplant First promotes living kidney transplantation among those who are eligible, which is better for the patients and also better for the planet. And there's also focused outreach for Indigenous and other ethnic community related to transplantation. PD Assist provides patients with daily home visit from trained caregivers to help with their PD treatment such that they can receive dialysis at the comfort of their own home, reducing travel and the environmental impact of in-center care. HES, the hemodialysis emergency response team, is a mobile nursing team that support care continuity during climate emergency, especially in rural and Indigenous community, addressing both resilience and also health equity. The Infrastructure and Capacity Planning Committee will develop provincial guidelines that incorporate cultural safety, sustainability, and community engagement in facility planning. Next slide, please. And these are, we've been gathering some key learnings from our planetary health journey so far. Adapting existing tools like the Cascade Playbook helped us build Canada's first renal planetary health strategy more efficiently. Diverse engagement across the professional disciplines and sectors brought valuable insights and solutions, so we will continue this collaborative approach. Planetary health is actually still new for many, and some people would think that is still about recycling and doing separate green initiative. So having that foundational understanding is very helpful. There are free trainings through the Learning Hub, Cascades, and other places that help everyone to apply a shared green lens to our work. Both provincial and local initiative matter. In this space, we learned that there are opportunities that can be developed in both ways, both provincial and local, and they can also help inform each other. And there are multiple initiatives that are frontline driven and have been very successful. We aim to support and scale them at the provincial level. From our environmental scan in the network, we know that there's strong readiness for change. So we just now need a clear process to identify and prioritize the many ideas that came forward so we can focus our energy, time, and resources on doing good work and deliver those high quality impact. Next slide. In terms of the next step, we are sharing and socializing the new strategy across our network and with other partners provincially and nationally. This ongoing promotion of learning opportunities such as the course on Learning Hub and Cascade, and those will continue. By the way, those courses are really accessible and people can do it at their own time, and it could take as little as 20 minutes to an hour and a half just to get an overview of the concept. To help invert the pyramid of provincial versus regional, we will launch a community of practice to support clinical champions and foster collaboration in environmentally sustainable kidney care. And every level can lead change in promoting planetary health. So if you are a kidney health professional interested in joining this new community of practice in BC, please email me to sign up. In terms of evaluation, the life cycle assessment collaboration with UBC Engineering and Planetary Healthcare Lab will continue and will also review and potentially add sustainability indicators to existing quality measures with a green lens. We aim to connect research with practice to support science-based decarbonization. And finally, we will continue to work with various provincial, national, and international partners so we can move forward together in advancing planetary health. That's all from me for now. Thank you. And back to you, Caroline.
Perfect. Thanks so much, Helen. So I think that's it's been a long time in making, and nice to hear that overview of what we've been working on for the past year or more, and all the work that goes into making the strategy. So we really look forward to working with everybody and engaging everybody in this. And I just wanted to start with this NHS plan to decarbonize their healthcare system, and really to emphasize that it involves everyone, that we're really grateful to everybody on the line today and people who are coming forward. Whether or not you're on our committee, whether or not you're in the community of practice, maybe you can find out in your own areas who is, because everyone's got good ideas that we want to hear, and to be able to enact these and to collect data on this. So back to the work that we're doing together. Basically, we want this strategic roadmap to integrate life cycle sustainability to overall decision-making framework. And so Saba Salim, as I'd mentioned, is doing her work on kidney replacement therapies. Last year in the rounds, we discussed about how Saba's research has demonstrated lower impact of PD and kidney transplant over hemodialysis, or transplant less than dialysis modalities. And she'd also done some work looking at the home hemo versus in-center hemo, and CAPD versus APD. So stay tuned for that in published form. And her work looking at kidney replacement therapies is really complemented by Saba Yousafzai's work looking at preventive kidney therapies. So I mentioned the user guide earlier, and that the current project is looking at the environmental impact of our chronic kidney disease pathway. So there's really a lot to that. I think many of us, those of you working in the lab, will become acquainted with Saba in the near future. We're collecting data on the lab work emissions as comprehensive assessment of that pre-dialysis pathway. Whoops, that picture wasn't supposed to appear right away. Sorry about the picture in the far right. It'll make sense in a second. But the outer circle looks at and describes Saba Yousafzai's pre-dialysis work combined with Saba Salim's work in the green, and then the combined goal of reducing our emissions. And my apologies about that seemingly odd graphic in the far right. But the point of that graphic, it was a nice metaphor. When I was recently at this conference, the menu had calories on there. And so we have this, this is the metaphor for what we hope to do, is that we can get emissions sort of a la carte. So you can look at your basic pathway, and then you can get emissions of dialysis, or you could get emissions of a hospitalization or a vascular access procedure. So we can kind of have an understanding of the environmental impact as we go. And we're even looking forward to expanding those metrics into other things, human health effects, costs, etc. There's a lot of people in Canada who are working on this. I think it's really worth celebrating that we are really leaders in Canada, and in most instances internationally, with this work. And I think it would really be beneficial for other areas to emulate the model in BC that Helen has just described. But really proud of our SNAP committee. We've got pediatric representation, we've got broad geographic representation, interdisciplinary representation, patient representation as well. So all working really hard to develop the science of environmental sustainability in kidney care. Please don't read this slide, but I've just put in green there the little highlights. A lot of people are taking this in vastly different directions to our general benefit. We've got some people working on ethics and how to discuss these difficult topics with patients, some working on education, some working on environmental determinants of glomerular disease, some working on optimizing transplant, nursing practices, etc. So as I say, there's many directions it can go, and I just encourage you all to have fun with it. So hopefully everybody remembers this slide from last year. We're trying to keep kidney health into the health promotion stage, early identification stage, and just a reminder that everything aligns beautifully in this area, that best outcome happens at lowest cost, at lowest environmental impact, and is most climate resilient. Helen mentioned the ways that many of you on the line here are practicing planetary initiatives without having specifically intended to do so, but I think it just is helpful to think about that framework, where you're involved clinically, and how different improvement ideas might be enacted. This should hopefully also be a reminder for everybody. It's a global look at where emissions come from healthcare. So this was a map of NHS England. Procurement and upstream of patient care is a big source. Our buildings, our waste and our water, and our travel to place of work. So all of that informs how we provide care. This is a pie graph that Andy Connors did back in 2010 in the UK, and it looks exactly the same as general medical care for kidney care. So we're heavy with the pharmaceuticals, heavy with our consumables and our medical equipment, and our need for waste. Overall, they found that dialysis care was 18 times more resource intensive than general health care. Lots of room for improvement. And just as we've been lauding, and I don't have to explain to this audience the benefits of prescribing wisely, but, again, just the nice alignment with the clinical outcomes. Again, when appropriate, reducing travel with virtual appointments when appropriate, home dialysis when this makes sense for patients, and ways to reduce waste, which we're really struggling and striving towards. Pharmaceuticals have high impact for a lot of different reasons. Number one, they're very energy intensive to make, to produce, to package, to ship to different places. And then sometimes they cause side effects which lead to hospitalization. They may not be all used. They may end up, as we saw in the very first project that our pharmacy colleagues were working on, as pollutants in our ecosystems. So this is a really good place to start for specific prescriber level intervention to ensure that disease-modifying medications are optimally used. To regularly review the patient's medication history with deprescribing when appropriate, and making sure that all medications have an indication. To substitute whenever possible oral medications for intravenous medications. To select the inhalers wisely, and that's a whole different topic, but there's lots of resources available in Cascades Canada for how inhalers could be substituted to more environmentally friendly ones, and as well how the inhalers themselves could be stewarded. To dispense smaller amounts of a new prescription if it's at high risk of an adverse event. So consider giving a patient a 2-week trial initially before prescribing a 3-month fill. And then, as we hopefully inspired with that initial slide, if medications are interchangeable clinically and financially, that we could select one that has a lower environmental impact. So some real life examples in terms of reducing, because in the waste hierarchy, we want to reduce the need for healthcare as much as possible. So we had the publication that was BC led on the planetary health kidney diet. Exercise, nature prescribing is a novel one. There's data showing that time in nature improves outcome. Lower carbon transport, we've talked about some of these things already. An important one here that ties into choosing wisely is their recent climate action recommendation, where they call to reduce unnecessary testing, treatment, and procedures. So I think a lot of time we do need to know, and a lot of time we want to know, and a lot of time it's somewhere in between and a little bit gray. And so appropriate use of lab resources, I think, is a really potentially impactful area that warrants some further study. So this was a study that was done by Dr. McNeil and colleagues, and they looked at people undergoing standard surgical procedures, uncomplicated surgical procedures. And a group of surgeons weighed into what a consensus of appropriate blood work would look like for these people. And then they looked at what was actually ordered, and they found that 76% were tested inappropriately. This had a financial cost and an environmental cost to the system that they quantified. And doing a, what I'll say, back of napkin analogous calculation for kidney care, this is taken right off of our Q6 weekly blood work schedule. So everyone here will be familiar with this graph and what's in it. I've circled some things that have not been assessed in that surgical assessment that was done. And I've put in red aspects of our monthly blood work that was included here. So all of this per patient, 513 grams for a routine panel of blood work, again, excluding some things. Calculation for if it was done monthly, once we transition to every 6 weeks, the difference would be 2 kilograms per patient. And using our December 2024 in and out report dialysis numbers, the annual BC patient emissions difference is 3 tons. So that's only the carbon metric. So you can see how small amounts really add up. And I'm not saying don't do blood work, but I'm saying there's lots of room for research into what an optimal frequency of blood work looks like. Many of you have had conversations with some of us on this slide here. Thank you for your input on our own sort of modified Delphi process of what would appropriate blood work look like in our patient population. So there's an opinion perspective that's in progress. So I won't name everybody here, but most of them will be familiar to you, and perhaps not as much our medical biochemistry colleagues. But we're all aware of this idea that if we order blood work, what automatically gets processed, like what's available at no additional financial or economic cost. So we hope to hear that from our medical biochemistry colleagues. We're getting Dr. Bevilacqua to weigh in on the pre-dialysis perspective, and our transplant colleagues in the admittedly much broader and I think more challenging area of appropriateness of blood work post-transplant. And thanks to those of you who have engaged with me in trying to get a consensus for the dialysis population. So I'll just stress that these are initial conversations and stay tuned for some potential future recommendations. So we need the whole team involved. And I want to give a real shout out to Gertie, who's our sustainability champion here at Island Health. And a thanks for funding some of our recent projects that we just learned about. So we're going to be doing an in-center hemodialysis carbon calculator footprint of our Island Health in-center hemodialysis unit at the Jubilee Hospital. And Gertie's going to be looking at some Going Green initiatives in the dialysis unit. So I won't read these out, but these are some of the ideas that are, I think, really appropriate for a green nurse. We're going to calculate things like how much time this takes, how much savings comes from it, and hopefully that could be a broader blueprint for what could be done in units to facilitate saving and reduce ideas in our clinical areas throughout the province. And we look forward to receiving improvement ideas through our community of practice as well. We have heard from patients about their perspective, and we recently published a perspective of a dialysis patient and a transplant patient. I will just state that Ms. Verdon is located in Alberta, so what she's commenting on may not necessarily, or wouldn't reflect the care that's provided in BC, but nevertheless, she gave a fairly poor environmental score to her, the systems delivering her care. She wanted a constructive focus on good process. She wanted help with home dialysis supply ordering, so she's a home hemodialysis patient now, and she's had suggestions for where to introduce these things. She also noted a real fear about emergency. Was there going to be capacity in the system to accommodate her treatment? So I think the summary from this is that patients increasingly are aware of these problems and welcoming discussions in this range. And I appreciate that these discussions can be difficult at first. I think there's room for nuanced conversation in this area as well. We don't want to say give a kidney to save the environment, but again, with nuanced consideration, Ms. Black, who was a kidney donor largely for an environmental reason, felt that some of that would benefit well in some of the pre-transplant counseling sessions. And lastly, I wanted to highlight some real challenges with how system barriers that are unintentionally present that are impairing improvement. So these authors recently published on how we waste a lot of acid concentrate. They did a back of napkin calculation here that looked at the amount of wasted money in Canada in unused dialysate that's literally poured down the drain. And they came up with some potential solutions, which I've listed some barriers to, which they discussed as well. So we could save it and use it for another patient, but there's a potential infection concern. Is there a real infection concern with a pH of 1 to 2 of that solution? Don't know, perhaps controversial, if that could ever be reused, and we need further information. Central acid delivery is another idea, but it's a huge thing to install and requires some upfront money. Maybe industry could provide smaller jugs so that we don't waste as much. And that was actually their most prominent recommendation from this. And then some other sort of utilization ideas, which really were burdensome to the everyday flow of dialysis unit. And so I just wanted to reflect, this is our group photo from our recent Green Dialysis Conference, how these kind of discussions are plaguing and challenging people everywhere, and that there was a lot of talk about bringing infection control in, bringing regulatory aspects in, bringing manufacturers in. So I think just rest assured that we know that there's big problems and that these discussions are in place to how system problems can be changed. But I think in the meantime, focusing on things like we've heard before, past rounds, Helen mentioned, everyday things that we could do right now are things that we'd really like to see. So that IV iron administration and reducing the biohazard waste in our unit. I think it's also important to accept that kidney care might look different. So this is not only a scientific challenge, but it's now a communication challenge, and really, I think, sort of a human behavior challenge of how we do things and things that might look different, and that we need a whole of system approach. I've outlined this before. Health Quality BC has emphasized environmental sustainability being really central. And I'm aware that I am limiting discussion time, so I'm going to be really quick talking about future accreditation. This slide is here for everyone's resources. I'm not going to read through this, but I want you to know that there are a lot of planetary healthcare resources out there. Helen mentioned some of these through Cascades Canada. And Health Standards Organization and Accreditation Canada have been very clear in saying that they are going to take action and that there will be explicit requirements worked in. Right now, they're going to be testing the Canadian Coalition for Green Healthcare's Green Hospital Scorecard. And this is a quick snapshot of some of the metrics that are being used in that scorecard. So we're hoping that with all of this background work that's been done, it's going to be, I wouldn't say a breeze, but definitely achievable for kidney care systems to be really aligned with these evolving requirements. So as we move into the future, my sort of summary thematic recommendations for people would be to routinely engage in conversations about environmental determinants of kidney health, to promote healthy lifestyle no matter what stage of disease patients are at, to optimize those preventive pharmacotherapies, to start thinking in a planetary health framework. It's going to be really essential if we want to reach our goals that everybody is involved and that we collect data along the way of things that we're saving. And that really, it is known that innovation is needed everywhere. A sustainable procurement strategy is probably the biggest way that BC as a community can tackle those larger issues. And I want to thank everybody for their enthusiasm and all the support going forward in this work, and happy to have a few minutes of discussion here.
Thank you, Carolyn and Helen. What an amazing way to start a Friday, especially on a beautiful sunny one. There was a question type which was quite specific from Spencer Graham asking about how the 40% greenhouse gas reduction goal was come to, what the scope and boundary of kidney care in BC Renal is, and where does it overlap with regional health authorities, and what categories are included in the target. I wonder if that question is probably better answered individually, but I think I don't think you're meaning to say that BC Renal and Kidney Care owns all of this, but rather, what are we doing, and then how do all the different health authorities and initiatives there feed in, and what is your communication perhaps with the various health authorities around some of your initiatives?
Yeah, I mean, it's an incredibly complex answer. And Spencer, I'll be happy to have a discussion with you. And probably our engineers could better answer that. But I'll first state that it's a stretch goal, and I'll second state that it's in compliance with the Canada's decarbonization goal, which is actually enacted as law. So it was very easy to come up with that as a stretch goal. The question of boundaries is a complex one. Healthcare Without Harm has a suggestion for how we decarbonize healthcare, and the vast majority of that is achieved through green energy. So we're lucky in BC to have green energy sources generally. But where I think we really fit in is in innovation in healthcare climate action, which is things like these reduce ideas. So we're working with our engineers for how we can make that plan a little bit more specific. And we're very, very, very much dependent upon you, our entire community, as you do enact these things, to give us some idea of how much plastic has been saved. And ideally, we don't want this to be too challenging for people. Like if there's some way that pharmacy could track, for example, how many doses of iron are given push instead of in a mini bag, then that would just be a simple way to report it. So I think the reporting structures are going to be worked out as well when we do this in-center hemodialysis carbon calculator. So that's very much a work in progress of how we're going to get that data.
That's excellent. As you were talking, I was thinking, like that could be like a counter, like how many mini bags of IV iron are used in the province and
Yeah.
by hemo unit, and it becomes a little bit of a compare and contrast and ask the reasons why. And there are often many reasons why you can't use the push, but if there aren't a lot of good reasons, that may change behavior. So I think that was an excellent example that you gave. We're coming up to time. I don't see any other questions in the chat, but I really wanted to thank you, not just for an outstanding and engaging presentation, but also just for reminding us that all of us can do something different. And I remember thinking, kind of, it's a pain to always take my coffee mug to the coffee shop instead of getting the paper cup. And now I can't imagine.
Yeah.
I feel guilty every time I get a paper cup.
Yeah.
So it's interesting. It is about sort of self-reflection and doing whatever you can in your moment, and all the little things and keeping on doing them, right? And I think
Yeah,
that's
absolutely.
what you've reminded us of.
I think the day will come when we'll look back on how we provide care now, and we'll say, "Can you believe we used to do that?" Yeah.
I think even when you start to calculate like how much the lab tubes cost and the draws and the needles and that they're all going in the rubbish afterwards, it's like, really? Like, is there not a better way to do blood work? Yeah, you're 100% right. Let alone the delivery of care. And I know that some of the pharmacies, this may be of interest to some of you, some of the pharmacies have reusable or recyclable dose dispensing for the medications for our patients who need to have a dose dispense, or what's it called, prepackaged pills. But again, insisting that those are standard, not special, will be really important. And all those things count. So again, Helen and Carolyn, thank you very much for all you do, for this outstanding presentation, for everybody that is working with you in the different health authorities across BC Renal. It's really inspiring and a wonderful way to start a Friday. So thank you. And thanks to everybody for listening.
Terrific. Thank you all.
Thank you.